Good evening, everybody. Welcome to this international webinar at Believers Church Medical College and Hospital. Today, we have a very important, very compelling topic on patient safety. How to improve communications in order to reduce hospital deaths. So, we have a very special speaker for this particular topic, and we have elite panelists too. The panelists, I would take the opportunity to introduce them. Our first panelist is Dr. Umesh Prabhu sir, champion in patient safety for decades. He's currently the recruitment director at Bolton University, UK, formerly medical director at Wrightington Wigan and Leigh NHS Foundation Trust, consultant pediatrician at Bury NHS Trust, clinical director pediatrics, Bury NHS Trust previously, and he was also the medical director of the Bury NHS Trust previously. He has received many awards for his work in patient safety, leadership, inclusion, and diversity. Following his own mistake, he developed keen interest in patient safety and ever since has trailblazed and taken leadership in that. He's given more than 300 lectures and 100 workshops on various aspects of patient safety. Professional regulation and governance have been his forte, and he has been nominated twice as one of the top 50 pioneering BME leaders of the NHS by Health Service Journal. So it's a great privilege to have him with us as panelist. I really am honored on behalf of this institution, and sir, we welcome you as panelist to this international webinar. Our second panelist is again a very distinguished faculty and a patient safety advocate, Dr. Subrajyoti Bhaumik. He's an international figure again, and he is currently the clinical director of quality, safety, and academics at the Peerless Hospital, Kolkata. He's also the honorary lecturer at the Institute of Clinical Sciences, University of Birmingham, UK. After his medical graduation from Calcutta University with a gold medal in obstetrics and gynecology, he has completed his MD in pharmacology from IPG-MER, Kolkata, and has more than 12 years of experience in clinical research, pharmacovigilance, and medication management in hospitals. He has been trained previously in clinical research administration from Stanford University, USA, and patient safety from Johns Hopkins University, USA. He's an assessor for National Accreditation Board for Hospitals and Healthcare Providers, NABH, and also dons many other hats in patient safety, clinical research, pharmacovigilance, etc. Sir, it's a great honor to have you in our midst as panelist. We welcome you to this international webinar, and it's a great privilege to have you share your perspective with us. Looking forward later on during the session.
Thank you,
Jyoti, sir.
Thank you, Professor Jacob. Thank you.
And to take forward the session and to introduce our distinguished speaker for the day, we have our moderator, Dr. Philip Matthew, who is our senior consultant intensivist and also associate professor of anesthesia at Believers Church Medical College and Hospital. He is a dynamic personality, and he has been a champion in advocating technological transformation at hospitals and healthcare settings. He has completed his anesthesia training in India and went on to train in intensive care in the UK. He's come back and ever since been consultant of intensive care at Believers Church Medical College Hospital. Dear Philip, sir, it's a great honor to have you in spite of your mad duties at the ICU with COVID patients, etc. You've really taken the time to come and moderate this session for you. Over to you, Dr. Philip Matthew, sir, for the moderation, introducing the speaker and handing over the session to him. Dr. Philip Matthew, sir.
Thank you, Jacob. Thank you for the introduction, and welcome all panelists and great speaker for the day. I would just like to give a few words of introduction to our guest speaker, Dr. Raj Verma. Dr. Raj Verma is originally from India, and he has done his MD Pediatrics from India, and from there on he had gone to the UK for his further training. He has completed his CCT in pediatrics and moved on through multiple NHS trusts in the UK, and he has been a leader of change in various trusts. He has also has done his FRCP, FRCPH, and MRCP from the Royal College of Physicians, Pediatrics, and from Edinburgh. And currently he works as the Associate Medical Director of the Integrated Care Pathway Group, which was formed by combining the trusts in North Cumbria and has formed the North Cumbria NHS Foundation Trust now. And he leads various groups which has been formed by the combination of the NHS Trust and to improve the performance and has been able to change the status, the CQC change from needs improvement to good in few of the areas. And he is working relentlessly as he has become the Associate Medical Director to improve the services in North Cumbria University Hospital. And he's a panelist in various groups, and he is making the change into developing a good communication pathway amongst all stakeholders of the trust, and to avoid avoidable debts and improve services. Today we have him here for a very important topic, and I am very sure that it's a very important topic for us and for our nation as well, where most of the doctors would come out of the hospital or come out of the ward, seeing the patient, and tell the relatives, it's okay, let's see, we'll see how it goes. But from there, how we can improve communication between families and the doctor, and between various caretakers, that is the healthcare workers, to make sure that what the doctor says is what the nurse understands, and what the nurse understands is what is really happening to the patient, so that we don't miss anything, and in that way give better service, better care to our patients. Over to you, Dr. Verma.
Good. Thank you for a very generous introduction. It's my privilege to interact with colleagues from India, and I'll just like to share my presentation. And to start with, so the communication is a really important tool which we sometimes find that it has not done well, and particularly in situations where things goes wrong. And always been my interest in improving communication, because I sit in various committees, patient safety panel, and I see on a regular basis that this is something where we need to make a lot of improvement. So to start with, I need to say why it's key for patient safety, because there is a various stakeholders involved whenever the patient comes to hospital, starting from ambulance, and then the relatives of the patient if the patient is not able to communicate, and then first responder who are taking the history, nurses, junior doctors, and then how the information get translated into the written notes, and then to the senior team, and then to various specialties, is a complex process. And sometimes you need to get information from support services like radiology, pathology, and then get it all documented. It's various situations, it can go wrong. As we all know that complaints, litigations, even patients avoidable death. If you do the audit program, we see that at various stages there has been failure in communication, which could have prevented those tragedies. And if we do review of the case notes of mortality of the patient, and then we always feel that there was communication gap due to which the timely intervention was not gained. So there are some of the issues which I want to discuss, just to make sure that if it is a problem. So there is verbal communication and non-verbal communication. So non-verbal communication is more important, and it's something which you can find out from the gestures, from the facial expression, and it's very important to pick on those non-verbal communication as well when we are dealing with patient. But when it's come to verbal communication, do we use any consistent approach across the hospital or across the department? Does all stakeholders using the similar approach when we communicate with each other? When it's come to written communication, whatever we say, do we back it up by writing exactly the same thing, making contemporaneous note? Do we use any specific format? Are we still using a separate medical and nursing notes? Because we should not be. Is it easily identifiable who has documented their name, post, date, time? Are we consistently following consent or confidentiality policies? Are we updating as we dealing with the patient or immediately after the patient or next of kin, update on the progress or if there is any deterioration in a timely manner? And the last but most important thing is, do we have a dedicated training program for improving communication to reduce the individual variation? And that's a very important thing for everyone to look at. So the resources and tools for effective communication, which I wanted to introduce, and I'm sure that a lot of people already know, is I-SBAR, is situation, background, assessment, recommendation. And then when things are going bad, then using stop the line or CUS, which is concern, uncomfortable, unsafe, stop. So that's how we escalate the policy. Effective communication is an open dialogue in which everyone is sharing the same model of how to handle situation and how to communicate. So we should not be feeling blank when we have to communicate about a patient. And the message, what we are communicating, it should follow a format where everyone can understand. So if we are not including all stakeholders in communication, then there will be breakdown. Also, there has to be a speak-up culture within the organization where people are not afraid of speaking up if there is a concern. And particularly, they should not be concerned that they will be blamed or their opinion will be dismissed. Important understanding is that we all are being trained to communicate in a different way. The nurses communicate very differently than paramedics, than doctors. And even if we are trained, we have got all variation in how we communicate, because communication skill training is not part of the medical education curriculum in many countries. And that's, again, is a problem. So when we would like to improve communication in any organization, we have to understand that there are two elements. One is improving the message being communicated, how we are going to improve the message. And the second thing is how we improve the mechanism of communication. And this is using the Swiss cheese model to explain what are the barriers. So if we look at the first Swiss cheese model, when the patient comes, it will be usually handover from ambulance crew or paramedics or from the relatives. And then it's being dealt by in emergency department, either junior doctors, nursing team, and then you wait for senior review. So there are a lot of interaction happening already. And then you will be looking for support services, like radiology, pathology, information coming up. We need to follow various protocols, policies. We need to prescribe. We also have to interact with various software nowadays. And that's the kind of dealing with equipment, software, digital patient record. Are we documenting clearly? Are we following organizational policies? Are we escalating to appropriate? And these all interact in a very complex manner. And with all this complexity, you understand that if we don't have a correct system of how we are communicating, how we are documenting, then it leads to an adverse event. I'm not saying that all interaction lead to adverse event. Majority get good outcome. But if you look at anyone with adverse event, you will always find that using this soft cheese model, that there has been failures at various levels. I'm sure that Umesh will come later on in the discussion with telling his experience. So how do we get everyone involved who can live with the same message? First, an important, identify all of your stakeholders. And I think nurses are the most important because they see the deterioration first and they escalate. So the nurses, junior doctors, and undertake a stakeholder analysis that how they feel about the communication, seek their opinion. I'm sure that all of them will want to improve because everyone who comes in the health sector, they came with the real purpose of making improvement and improving the life of patients. So then we have to involve training program, some role playing, and then it's a big transformation program which you have to involve in your organization. Communication remains the foundation of patient safety. Improved communication means improved care, and handover is very, very important. I'm sure that all of you remember being consultant, that someone is ringing you and describing a patient and then spending 20 minutes time describing to you. And at the end of 20 minutes, you got no idea what the doctor wants from you. So it's very important to have a system. So the aim is to ensure that patient and families are safe in the hospital. Patients have timely and equitable access to service. You want to improve confidence of service users in the hospitals. You want to improve the reputation of the hospital, and you want to produce future generation of healthcare workers who are going to improve communication and they take communication seriously. And in fact, it will also improve the cost and delivery of care of patients. So what is I-SBAR? So it's also called an I-SBAR. It's a communication framework to avoid failure in communication. Originally, it originated for nuclear submarine services. They used extensively in medicine. It's safety focused, it sets expectation, it involves teamwork. Very important in acute clinical scenario. It can be used for handover, ward round, clinical documentation. I have already introduced this system in various outpatient handover, but again, acute clinical scenario is something which is the most difficult one because it involves lots of stakeholder and training program, which I'm currently working on. So first, identify yourself and the patient, situation, describe the problem, some of the related background of the problem, what is your assessment, what kind of help you need, and recommendation what you should happen. And this is the simple form where you can adopt this tool in your environment, whether it's a ITU or whether emergency medicine or acute medical ward. You can design the form. It should be one A4 form. You can also add D, which is decision making. So once you develop I-SBAR, you communicate with escalate with a senior colleague, then you should come out with a decision, what is the best decision for the patient. And this is just a display of whenever a patient is coming, there is so many people involved in communication. I'm using some of the anonymized scenario where patient harm has happened. So this is a teaching hospital, 1 a.m. So wee hour where people are asleep. Registrar is speaking to consultant on call about a CT scan of abdomen, who came with a history of pain abdomen for 6 hours. There was mild distension and CT scan was suggesting a perforation. Consultant, funny enough, advised to manage conservatively. IV fluid, painkillers, antibiotic. And then registrar and nurses got busier because they have to deal with some other emergencies. So I'm not sure whether this patient had appropriate monitoring. 4 a.m., one of the nursing review happened and BP was falling. You can see 82 systolic, and it was really difficult scenario. Crash call, ITU, registrar, intubated, ventilated, multi-organ failure, peritonitis, sepsis. Patient died. Serious incident, case notes review, and patient safety panel discussion was happening. I was quite surprised that how come this is not a rocket science. If someone has perforated, which confirmed by CT scan, this patient needed to go to theater at that time rather than putting on conservative management, because you would expect this patient to deteriorate anyway. So this is one scenario. Another one, 48-year-old presented to ED. Ambulance crews said that he got headache. In the handover sheet, there are various things written, but somewhere it's written blood pressure 182, 120. Examined by junior doctor who diagnosed acute headache due to migraine. One of the nursing documentation still say BP 196, 136. He was making some irrelevant statement, still complaining of headache. Junior doctor diagnosed acute migraine, gave IM sumatriptan. Discuss with consultant, no documentation anywhere that discussion happened with consultant. Patient sent home. After 12 hours, patient came back. Again, managed in ITU, died same day. Actually, he had subarachnoid hemorrhage, and because of very raised high blood pressure, and one of the complications of sumatriptan is hypertension. So he was given a medication which probably might have worsened his blood pressure. And the second thing was that blood pressure was not managed. And I think with this sort of presentation, you would have expected CT scan to happen on that very admission. This is a 12-year-old boy with 3 months history of recurrent vomiting, some weight lost. There was history of depression, a sibling known to have autism. A locum consultant saw in the clinic and thought eating disorder. But there was various change within the locum consultant because of the problem with recruitment. For next 1 year, this patient is moving from one consultant to another consultant, nothing changed. Pediatric dietitian and clinical psychologist disagreed with the diagnosis of eating disorder. However, this diagnosis carried on. Regional gastro team involved, the PEG tube was inserted, anti-reflux medication was given. One of the substantive consultants took over this patient. He was convinced that there is some psychological problem, and probably mother is just, too much of a problem coming with same issues, and he thought that maybe refer to social services. So started taking opinion from pediatrician at 12 years of age. Now he's 15 years of age. Again, it was one of the routine open access admission to hospital, giving some of the medications and blood test. And one of the consultants said, let's do a brain scan. Brain scan confirmed germ cell brain tumor. So colleagues were sitting on him for over 3 years of age. No one questioned the diagnosis of eating disorder. People kind of ignored the advice from dietitian and clinical psychologist, had poor outcome, radiation. Next one is 78-year-old single male admitted with a fall in his care home. Came to ED, X-ray done, CT scan done, no brain hemorrhage, no fracture. There was some concern related to memory as he was appearing confused. And they thought could be early dementia. Dementia nurses were involved. He was discharged back to care home. He was readmitted after 6 hours, collapse, unconscious, sepsis, multi-organ. So here sepsis was missed. He was appearing confused. Why it was not thought of it? So again, this is, but looking through the notes, there was some suggestion that there was some problem with urosepsis, which was missed. And again, there was major problem with communication. Senior clinicians were not involved, and communication not properly documented. This one is a 32-year-old single female who was admitted in the morning with chest pain. Again, there was past history of DVT, which was missed in history taking. It was managed as possible cardiac event. All the troponin levels were done, and the patient was moved to medical ward. Cardiac event was excluded. And CT scan was done, which confirmed pulmonary embolism, started on anticoagulant. And as it was, the CT scan was not reviewed by senior consultant. Junior doctors saw the CT scan and discussed with consultant over the phone, not documented in the case notes or any discussion. Mother was feeling better and wanted to go home because she had a small daughter to look after who was currently being cared by a friend. Patient was sent home, same day with anticoagulant medication. Came back following morning, collapsed, intubated, ventilated, died. So that's kind of few scenario, but I'm sure that we all can look back in wherever we work on some of the death adverse event, and we can find that there were some problems in escalation, there were problems in communication, and we can make improvements. So I think the key task for us, all of us, to develop an educational package, to train staff. We need to test the education package. Is that appropriate for your setting? And implement I-SBAR tool where nurses, doctors, they all talk the same language. That once you decide that, yes, that's the tool you want to use, then you have to get the support from the whole organization, because it's not just you need to implement in one department, it has to involve the whole organization. You have to use a training program so that it gets embedded within the culture. Once you implement, it's very important to process measure, percentage of staff who have been trained, how many are there using, because what happens that any transformation or any program, there is a resistance to change. And sometimes people change for the sake of, yes, they want to be, listening to people and changing, but then soon they go back to their own old practice. So we need to link with the audit to see how change is happening, and also whether we are improving the outcome. So no one is perfect. All of us are on a spectrum in terms of how we communicate, and even our own understanding that it's causing problems. And they need to understand that it's something we need to make improvement. The big points in favor of this transformation project: it doesn't cost money. It's a small change which makes big improvement. It fits in with the theme of continuous improvement for any organization. However, it needs major change in teaching, training, and these clinical leaders have to lead by example, particularly senior consultants and senior nursing staff. Thanks for listening. The single biggest problem in communication is the illusion that it has taken place. I'd like to quote George Bernard Shaw and wish you all a safe 2021. I'm happy to have further discussion so that I can also learn some of the ways how we can improve. Thank you.
Thank you, Dr. Verma. Thank you for the wonderful talk. And something that I liked so much is the I-SBAR, which is extensively being used in all the NHS institutions. And we too in our institution are following I-SBAR across nurses and doctors. Let us hear the comments from Dr. Umesh, countering what Dr. Verma has discussed. Over to you, Dr. Umesh.
My slides, please. And Raj, it was a fantastic presentation. And I think you gave some very good examples of some fantastic cases. And I think that is what we see common theme in everything. And what we see is poor documentation and missing vital signs, and many doctors missing the diagnosis, not just one or two doctors, including seniors. And vital signs have not been recorded properly, missing important flags in the history and in examination, and repeated mistake by seniors and even the doctors. That's the reason why we should stop blaming anybody. And I think what I liked about your message is training, 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 education, 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 and giving the regular feedback. Because change is not easy, particularly once you're at a particular age, you have got fixed mindset and you don't want to change. That is why Mahatma Gandhi said, be the change you want to see in the world. Once you see as a senior leader, you can change anybody. But it has to be supportive, it has to be learning culture, it has to be training properly, and human stories touches human soul. And I developed interest after my own mistake, but I missed 26 rib fracture in a child of 6-week-old baby. And there were two babies with the same name, same date of birth. And that is how I missed the diagnosis. And that is how I developed interest. Can you have my slide, please? So what I'm going to tell you is, I'm just going to very briefly tell you what Raj has said and some of the important message and a couple of very interesting cases. And I want to start with my own wife. I had a very good treatment when I had sepsis, but unfortunately my wife was not lucky. She had perforation of the uterus. She developed pelvic abscess, and she was, she received urgent treatment, and that was because of unnecessary investigation. And my friend's wife recently died. She was in intensive care. She also had unnecessary investigation by a consultant. And she told him, I don't want to have colonoscopy, but he did it. And he also had the problem. And communication is the most important thing. And in UK, 70% of complaints and 80% of litigation, there are communication issues. 70% of complaints and 80% of litigation, there are communication issues. And I just want to give you 3-4 cases of miscommunication. What happened? A nurse gets a urine electrolyte result. She rings the registrar on the phone and she tells him sodium 113. And he heard it as 130. And he thought it was normal. So he didn't change the treatment, and patient developed severe intracranial hemorrhage and patient died. And that is what miscommunication. And I want to tell you one more. 2 Indian consultants, somewhere in the UK, they were doing delicate procedure and they were talking in Hindi, and they were told not to talk in Hindi in theater. But unfortunately, they continued the habit. and consultant A tells his colleague to give heparin, which they injected 0.5 ml. He injected 5 ml, and the patient died on the table, and both were charged with manslaughter. So you can see the consequences for doctors also can be pretty serious. So far in UK, 80 doctors have been charged with manslaughter. And because in UK, regulation is very, very strict. At present, I'm helping 3 Indian doctors who are in difficulty, who have been suspended, and they have been suspended for a long time. So my sincere request, Raj, as you rightly said, communication is most important. Healthcare used to be very simple and ineffective, but today healthcare is very complex, very highly effective. But we got very dangerous drugs, we got dangerous procedures, and that is the reason why effective communication is extremely important. And I'm really glad you guys are providing training for the junior doctors and for the nurses, for everybody. And most important is effective communication. And now, with digital transformation, I'm pretty certain communication will improve to a great extent. The same thing with artificial intelligence. They have recently tried in China, radiologist against the computer, and computer consistently won in diagnosing tumors in breast cancer. So I think in future there will be digital transformation, there will be artificial intelligence, and I think we will improve communication, and patient will demand more and more, because now you got internet, now you got mobile phones, and that's the reason why I'm really glad you are providing communication skill training for everybody. And I just want to stop there because we will have very good question and answer sessions after Subhrajot. Thank you very much.
Thank you, Dr. Umesh. It was crisp about the communication requirement and how that has to be the most important part in our practice. Dr. Subhrajyoti, would you kindly add on to the discussion, add on to what we already spoke to?
Thank you, Dr. Matthew, and thank you, Dr. Raj Verma, for that wonderful presentation. I think you opened the lid for the Pandora's box, because communication is lesser we say, more we kind of understand what went wrong. So I think the most important thing in Pandora's box is to define few things, which Dr. Umesh Prabhu has also very well mentioned, is that the communication, I personally believe, has been taken for granted in the medical practice. And as your last slides were so important, that the biggest illusion about communication that it has taken place, I don't know why my video, yeah, now I started my video, okay, is the notion. And, being trained in India, and I'm sure Dr. Verma would also agree, Dr. Umesh is also the son of the soil, they would agree that, there's a very hierarchic communication protocol when it comes to medical practice. So the example Dr. Verma gave about the very unfortunate perforated patient, I think the life would have been saved if the registrar had the courage to tell the consultant on face that you are wrong this time, probably you cannot be right all the times. This is not ingrained in the system. That is what I would say. I'm not saying that we need to kind of, disobey or not respect our seniors, but what I have personally felt is that sometimes the seniors, or I would say the respected seniors, need to be told that medical science is an ever dynamic changing field, and a lot of things have changed in the medical profession. So you really need to get, you need the help of the young people, young medical professionals, to kind of treat the patient properly. Having said that, the other hierarchic communication which happens is between the doctors being at the apex and, subsequently believing that everybody else is down the mountain, starting from nurses, the pharmacists, and, the other paramedical staff. We are not ready. When I say we, the doctors are not ready to hear anything constructive as well as critical from these three sections coming together. We should understand that we are a football team. The doctors are probably they are the front people who are taking the lead, but the defense is also maintained by the nurses. So sometimes we have to listen to the defense of the football team, that yes, probably if I don't listen, we might lose a goal rather than scoring a goal on the opposition. So This is a very important thing, what I have personally seen in my limited knowledge and limited experience of last few years in India and having worked abroad in the United States, that this hierarchic, wherever the institutions have been able to bring down this hierarchic communication within the doctors, within the community, and inter community, I would say, then the patient safety has really improved. And last but certainly not the least is communication coming from the patient. There are studies and literature says that one of the biggest issues of communication is that people are not ready to listen. A good communication begins with listening attitude. How many of us are ready to listen to complaints made by our own wives? We are not ready to listen. We will jump onto conclusion that you have come up with a bag of all wrong information. I think we have to really start it at home, because and I try doing it. I'm failing miserably. Sometimes I'm failing, but I'm trying to incorporate this, that try to be a good listener, then you can be a good speaker or an orator or maybe a communicator. And very nicely, Dr. Verma mentioned about the non-verbal communication. Sir, your point is extremely important, because this has been ratified by a BMJ study, where there was a study between the doctors on one hand and the pilots on the other hand. And they were asked about how frequently the doctors had the courage to kind of speak up against errors in front of the seniors. And the same question was given to the pilots. And 100% of the pilots said that yes, we have the courage, because saving the lives of the 300 people on board is a much more important thing than to take care of the ego of the senior pilot. So I think time has come that these things have to be incorporated into the medical education. I'm happy that the National Medical Commission very slowly yet steadily has incorporated communication in the medical practice, but unfortunately this is not present in the curriculum of the nurses. Unfortunately, this is not present in the curriculum of the pharmacist and the paramedical staff. So I don't think if, only the doctors can do justice to the communication puzzle. All the jigsaws, all the portions have to be put together. And last thing I would like to say is that the NABH plays a very important role in India, being an assessor for the National Accreditation Board for Hospital. I think NABH has done a remarkable job for empowering communication in the country. This is the body which talks about nursing empowerment, which can save lives. Nurses don't have to wait for getting a green signal to do CPR. That is clearly mentioned. These can save patients. It mentions about prescription audits, which are nothing but communications of wrong prescriptions which are being done by the doctors. So I think kudos to NABH, that NABH has started the culture in this country. At least it's a very young culture. It's only 10 years old, but I'm sure as we grow older, the system grows mature. Communication will be improved subsequently by NABH as well as NMC, both playing their part together. So thank you very much. And once again, thanks to Dr. Raj Verma, Dr. Umesh Prabhu for those wonderful insights. Thank you.
Thank you, Dr. Subrajyoti. That was a clear perspective of the Indian scenario and how NABH and NMC, all the stakeholders are trying to improve services by incorporating communication as part of our services. Jacob, can we open the floor for discussion?
Yes, absolutely, Philip, sir. The floor is open for discussion. Please ask your questions. Delegates, participants, if you can please ask your questions, you can type it on the chat.
Yeah, to begin with, I'll put forward. Sorry, I'll just come up with my own thoughts on what I have learned in the UK. Actually, being an anesthetist, actually, probably we don't. We are the team who talks the least to patients. In India, actually, anesthetists, you don't even see anesthetists on the just outside the theater. Just before coming in, you will see, and then the patient goes in. The surgeon comes out and talks to the family. We'll just make sure that the bystander the relative has seen that the patient is alive and you are out. But the scenario changed totally when I moved into intensive care. And the extensive discussions that the consultants do with the families in the UK was a real eye-opener when I came over there. And that's how, and something that is amazing, I was actually surprised by Dr. Verma's and Dr. Umesh comments on, in spite of all these communication scenarios in the UK, the amount of issues that are happening, I just cannot accumulate that thought. Because in India, actually, in spite of very poor communication, we don't have much issues related to communication. Yes, sir, you can.
Yeah, I think it's a situation of not knowing what the issue is. It's like these are like tip of iceberg. A lot of good things happening in NHS, which I'm not sharing, and I'm sure Umesh is not sharing. So what we are just kind of sharing is things where, adverse event happen or harm to the patient, and then so a lot of good communication happening, which is saving patients' life. And in any healthcare system, whether it's India or anywhere, where say that it's not a problem, I will be really surprised. You need to go deep down, looking at all the adverse event and then investigate, and then you will know that it's a big problem.
I think it's mainly there is advantage in the Indian system, advantage in UK system as well, because too many steps spoil the broth. So anesthetic is going and talking, then consultant going and talking, nurses talking, it creates a lot of confusion in the family. So there are advantages in one person taking the lead, there are disadvantages. What we got to understand is, as Raj clearly said, there are problems in Indian system because in Manipur we had a conference and they presented some amazing cases where they have made a mistake. And the evidence from WHO suggests in 29 developing countries, probably 42 million adverse incidents, resulting in 7 million deaths every year in developing countries. Whereas in developed countries, we are open. So what I've always said is India has got good things, America has got good things, UK has got good things. We have to learn from each other the good things and get rid of the bad things. And that is what Shakespeare says. Heaven is empty, all devils are here. That is what Shakespeare says. So what we got to do is, I was amazed in Delhi Shakespeare Hospital when I saw amazing computers. And that's the reason why. Your own training program is a fantastic experience. And this is not there in some part of UK. So what we got to do is learn the good things from everyone and get rid of bad things. Because one day we all will be patients. So patient safety must be our top priority. Whether you want it or no, you will be a patient one day. And secondly, what we got to get rid of this hierarchy. I've always said, everybody is a leader. Everybody is born to win. I've always told my juniors, I'm not perfect. You have to tell me when I make mistakes. And that relationship is extremely important, and leaders must lead by example.
Yeah. Another one is the I-SBAR, and the second is EW score, early warning score that we have
We all
from
use.
the UK. And like empowering nurses, I think is one of the greatest thing that should happen in most hospitals. I think most of the corporates are now coming up with regular training programs for training the nurses. But again, with NHS training most of our nurses from India, we train them and then they move on to the Gulf or NHS, and we find it so difficult to keep the quality up, because we'll have now every month I will have at least 10 nurses leaving my unit.
Same here.
So we train them. We got I-SBAR, we got EW scoring, we have developed the RRT, rapid response team. All of this from what I've learned in the UK, and we have come up with that. But again, and we follow the kind of dignity of labor thing that we like anyone can talk. even in our morning discussions, in our rounds, anyone can talk. Even the nurse, the junior doctor can ask that questions. They can say, no, doctor, I feel this is it. I think it didn't happen like that. They are open to follow a flat management system in the unit. We always say we are one team. We are all doing the same thing for the same patient. It's not that I am leading or you are leading, but we are all doing it together. I think that is the key to reducing errors and you give them the confidence to open their mouth and talk or to ask questions rather than saying that, as Dr. Subrojoy Jyoti said, I'm not sitting on top of the mountain, but we are all sitting on one flat plane. So probably that is the key to that's what we have to do in the nursing curriculum as well. Probably, as he said, the nursing curriculum or the pharmacy curriculum doesn't have anything related to communication. Probably is something that has to change.
Right. I just want to make one point, and as you correctly mentioned, Dr. Matthew, that we have been the training center for the world. We train the best brains, and we train the best nurses, we train the best doctors, and we lose it to the developed countries. And this is, I think, one of the biggest misfortune India has, because if we would see, and this is the same problem which is actually gripping Calcutta as well in our own. So you can't, the corporates being a private hospital ourselves, we can't really put a bond or something in place that you would like to serve us. It's only that if these people feel connected to the roots, then they would stay back. Else, I think the discussion also has to come in terms of what happens with the communication breakdowns. And there it comes to the assaults, the kind of assaults which the healthcare workers in India have seen, which I was astonished when I went to WHO and I saw that the World Health Organization is working for healthcare worker safety across the globe. So it is not that, as an Indian, I always felt that anything going wrong, breaking the doctor's head or assaulting the nurse was a common feature in India, but it is very common in many developed countries, including the states where they gun down the doctors if they don't find them up to the mark. I mean, this also has a social implication in India. We have to have our regulations very, very strict. People should feel that they can do communications properly. They are protected. They are in a protected environment. And I think the government, though, has done some bit during the COVID-19 era where they have streamlined and strengthened the Protection Act for healthcare workers in India. Still a long way has to go, because I personally have, spoken to many friends who moved to India, moved to United Kingdom from India. Is the only thing which was on their mind, apart from working in the NHS, which affords, gives, of course, better salary and better working environment, is we will not be assaulted. So this is something, healthcare worker safety has to be also brought into highlight in our country if we have to retain good brains and good nurses, as you mentioned, in your ICUs and or in my ICU.
I just want to tell you a few things. In India, assault of doctors is common. In the UK, manslaughter charge for doctors are common. CMC has to realize charging manslaughter doctors is not a way to improve patient safety. So far, 86 doctors have been charged with manslaughter, and Baba Garba created a lot of tension in the medical community. And in the UK, in the US, they gun down the doctors. We doctors must take the initiative. We have to work with the politicians. We have to work with the media. We have to work with the public, because without doctors, there will not be good patient care at all. And that's the reason why. And we doctors must, I'm always saying, what we did was happy staff, happy patient. And that is how we reduce harm to patient. Anybody can come and see me. I used to meet them myself. And I told the family, we are not going to dismiss a honest doctor or honest nurse for a honest mistake. Only bad doctors must be removed. And the time has come for the profession to take the lead, because we are the most respected profession. Doctors in the UK scored 92%, nurses scored 96%, politicians scored 17%. So what we got to do is, we doctors must take the lead. We have to work together. We have to educate everybody, because we got the knowledge and we got the respect of the community, and we must make sure we are always trustworthy and we can transform this. Because doctors have been killed by the people. And that is shocking, absolutely shocking. So that is why we all have to work together and we must take the lead.
Can I ask something, Dr. Verma? Like,
Yeah.
how do you manage the international recruits, the doctors who are coming from India or Sri Lanka or from the Asian subcontinent, in developing the communication skills that are required? Because from Kerala, that's different. From metros, it's different. But when they come in there, they're not here. We are not obliged to talk or continue the communication pathway. But there you are obliged. There is a system that they have to follow. You train them.
So we do quite well in Cumbria because anyone coming from India through international recruitment, we give 3 months of robust induction, not just 5 days, 6 days, 3 months. So for 3 months in Cumbria, there is a locum doctor doing their role whilst they are being given very close supervision and let them develop the skills to work in NHS. So they are not kind of pushed into the system and start working and committing mistake. And even after 3 months, there is kind of weekly catch-up meeting with supervisors. So a lot of time we spend, and before even they start, once we know who is coming, we send a lot of informations, what they need to know about related to the specialty. So, but yes, it's a difficult thing. Even with, I can give you an example. There was a recruitment in psychiatry happened 3 years ago, and then we gave all the information governance training and that we have to take all the information confidential. And immediately after the training, they left all their computer without logging off and they went for the lunch. And then I have to bring them back and tell them. So they sometimes, we find that you are doing the training and they are considering, oh, it's just a tick box. But they need to, whatever they learn, they have to make sure that they are putting in practice. And that's where difficulties are. That just giving training is not good enough. You need to make sure that they are putting in the practice and slowly, but also to give them a lot of good feedback, things which is their strength, because it's very easy to become critical of Indian doctors and reduce the kind of their moral will go down. So you have to give them feedback what they are good at. Because they all come with lots of strength and lots of skills which we don't see here. So we give both. So start with positive and then give some of the areas of improvement rather than negative. We said these are the areas I need to improve, and these are the support we can give you to improve. So it's kind of a journey, but I think we have developed a very good system in Cumbria where we are getting every year international doctor, and they all are helpful and making progress in their career.
Thank you, sir. And one more thing I wanted to ask was, is there a special format that you follow with the discussion? I mean, with the family discussion?
So it's very important. I'll give you an example. When you ask about discussion with family, we have got patient information leaflet, okay, for almost every condition you can imagine in NHS. There is information on NHS Choice website. These information which we share with patient has got kind of very simplified, version where you don't have to be a medic to understand. But again, there is a lot of individual variation how we communicate with patient, and that's what I'm trying to reduce with this project of I-SBAR. That and even with experienced doctors and nurses, some are good, some are still learning. And so there is a lot of, we know wherever we work, we know within the team who is good communicator, who is not. So this is a kind of progress, work in progress, if you like. But best way of communicating with a patient is to ensure that you are giving the information which they understand and check back whether they have understand. And if you want to use a model, I would say Calgary-Cambridge model of communication, which is very good. It's available on YouTube video. So suppose if you explain a parents about a child's condition, the patients when they are attending with doctor, they are nervous. You understand as a doctor that whatever you have communicated, they have understood, but it's not correct. You have to check back after you finish the conversation what they have understood. And if they tell you back exactly what you have explained, that means that they have understood. Otherwise, you will just assume that you have communicated. So that's kind of Calgary-Cambridge model gives you how to communicate with patient and parent. The other thing which happens, and that in pediatrics in particularly, we always copy the letter to the GP to parents, so the parents will know exactly what's going on. But it doesn't happen in adult patient, even in UK in various departments. And there are patients with chronic condition where we expect them to self-manage some of the minor problems, as for example, patient with pulmonary heart disease or asthma. They should have some tools of managing acute exacerbations, but how they will know? We don't send copy of letters to them. NHS is also promoting tools for involving patients in their management, or decision making involving parents or patient. It's not going to happen unless we communicate, unless they know well about their own condition. So there is various degrees of advanced communication we can do. But I think basic we can start with I-SBAR. Basic we can start with empowering our nursing colleague, empowering our frontline clinician to have a standard across the organization. The transformation which I'm starting in new year in my organization on I-SBAR, I'm more than happy if anyone from your organization want to take a lead so that I can share, and if they want to develop the similar thing. Because unless we audit the case notes, unless we look at all the mortalities, it's very difficult to pick up which one was avoidable death, where the communication failure happened. And that's the kind of, we got a system in UK where we know, we audit, we look at and discuss in the patient safety panel, and those are the system needs to be developing.
I think introducing I-SBAR across organization the most important thing, because everybody talks in the same language. That's what I felt when
Absolutely.
we saw EWS for the moment a consultant or any doctor gets a call from this patient is deteriorating. Okay, what's the new score? With that, it's done. With that, the communicate, you start from the same platform. He understands what he's talking, I understand what I'm listening to. From there on, we build up the case.
Yeah.
Okay, what is it? Why did he come? Everything goes in that same pattern. I think we should formulate something. I mean, based on I-SBAR, we should have every organization. The system might be slightly different in many institutions, so we'll have to probably institutionalize our. Based on I-SBAR, we should probably develop something similar, which every stakeholder can understand and relate to when they discuss amongst themselves, so that everybody understands, or everybody is know, okay, this is what I'm going to listen next, this is what I'm going to ask next, and finally at the end, okay, we have a decision, or I know what
Absolutely.
I'm supposed to do, or I know what he's supposed to do. I think that is an excellent model that we should probably develop across institutions, and within the organization across stakeholders, so that we definitely reduce communication errors and save lives rather than avoiding deaths. We probably save lives with that.
Right.
May I direct this question to Dr. Raj sir again? Sir, what about preparing family for poor prognosis? Or how do we communicate an error in treatment to family?
Okay, that's pretty easy, because here, whatever is happening with the patient, you are supposed to discuss with families. So it's not an optional one. So whether it's a pediatrics or ED or ITU, you have to have a session where you are. So the only issue is whether you got a consent to share. In pediatrics, it's easy, you discuss with parents or carer because there is no problem. But in adult, when we are dealing in adult patient, and they have to consent who we can share with information related to their health. So if you know that there is consent already in place, you can share the information. When we share the information, it's very important that what degree of information we are sharing. Is that involving with something bad prognosis? Is it something which is bad news? So that we got a separate room. We go there there is no mobile phone, no bleeps. You take it away so that you can't get disturbed. It's a room where the family will be supported by a nurse when you break the bad news. So we do it very sensitively. But again, whenever we are sharing bad news, whenever we are sharing something which is not good news, there is a likelihood of you upsetting them. There is a likelihood of they not understanding, so you have to repeat. And sometimes, even if you explain, because with the stress, amount of stress they understand, you have to offer that I'm available for talking to you again. And because sometimes one session may not be enough. And it has to be someone, a key worker, who has to take the role of working with. Once you leave, someone is checking back with. Again, you can't use I-SBAR tool for those sort of sensitive situation, because each situation will be different. And that's a very high advanced level of communication where empathy is very, very important. Sensitivity is very important, and how you deliver and there is a separate training on how to break bad news, so it's entirely a different communication skill sets, and it can take again another hours for discussion. But again, I would say that it's done very well in NHS, and we got a system, we got a separate room, and it's done is very sensitively.
How about how do you deal sharing the medication errors with patients, or treatment errors with patients?
So it has to be done. You can't hide it, because the moment you have done medication error, you have to document. Nurses and doctors, you have to raise as an incident that medication error has happened. But it's your duty as a doctor and nurse to explain this to patient that this has happened, likelihood of any side effects or overdose you need to mention, and you have to document in the notes that you have already communicated. It's not something you can hide.
Thank you, sir. Thank you. That has been an amazing session, and we have got wonderful.
Dr. Jacob.
Yes,
Dr.
sir.
Jacob, in our training,
we have our director and CEO, Dr. George Chandy, sir. He was also the former director of CMC Vellore, and it's a great privilege to have him. And ladies and gentlemen, we present to you Dr. George Chandy, sir.
Good evening.
Thank you, Dr. Raj Verma, Dr. Umesh, Dr. Bhaumik. Thank you so much for a lovely session. Thank you for what you've taught us. But this is a major lacuna in our training program, as you know. So how many hours of training do you think we should put into our medical curriculum in terms of communication?
I think it's a very good question, but I have got a practical solution.
Yes,
the
sir.
practical solution is there is no need to have a separate training program in communication. My solution is whenever we describe any clinical condition, whenever we teach anything, we teach at the same time how to communicate at the same time. So communication should be the part of, suppose we are discussing about the stroke, management of a stroke, then whilst you're describing medication, you describe communication. If we implement I-SBAR tool within the organization, we are already halfway there. But whenever we describe any clinical condition, one of the domain should be the communication of that clinical condition, how to communicate to parents about this condition, and how to do with sensitivity, particularly if things goes wrong. So it should be part of our daily discussion with any condition.
That's an excellent suggestion, Dr. Raj Verma, because then it becomes a part of our lifestyle.
Culture. It's cultural change.
Cultural change. We don't have that at all, as you know. So I think our final years are just finishing this year, and we'll try and include that in our teaching when we do our clinics, and then do that with them as interns. Thank you. Thank you very much.
Thank you.
So just to come in here, we have incorporated a separate module of communication to patients as part of our training in pharmacology in second year. And our students are testimony for that. So I think it works, and especially for prescribing and certain other aspects of treatment, we do teach them communication skills, and also we check their competency through various OSPI stations. So that we are doing on a regular basis, though it was not previously a must-do domain with the curriculum, but nonetheless has become a must-do domain in the latest CBME curriculum. So right from 2016, we are really grateful to our leadership, like George Chandy sir, for pushing us to incorporate all these wonderful sessions into our curriculum, and we are grateful for that. Thank you. And any comments from our panelists?
Yeah, Professor Jacob, can I ask a question to Dr. Raj Verma? Sir, I wanted to ask your experience of how to improve documentation practices, because verbal communication, you can have these scenarios. Documentation is, as my experience is, and I went to one of the largest government medical colleges in Calcutta, and there were so many patients as interns. Even if my teachers would like me to write the entire history, we were not able to do it because we had to take care of so many patients. So your suggestions on how do we improve documentation practice?
That's a very good question. Documentation is problem all over the world. It's not just, but again, there are certain systems here. So if you get a referral from GP, we have to write back with a letter. Whenever we are seeing a patient, we are documenting the case notes, but improvement, I would say that yes, even in UK, there are problems, there are individual variation, and using the I-SBAR tool, so situation, you write the problem list, active problems, which patient is coming with. Background, you write what are the relevant past problems related with this active problem. Assessment is your physical examination, investigations result. Recommendation is your plan of management. And that plan of management may be to seek advice from a colleague, maybe escalating to senior, and at the end, a decision has to be made. So if everyone follows this format, it will be a standard format of documentation. So we got electronic patient record. So when I first started in Cumbria in 2016, the CQC rating for my care group was inadequate, which is kind of worst rating you can have. And it took me 7-8 months to turn around into good, because once I went there, I could clearly see the problems. And one of the biggest problem was communication and documentation. So I implemented I-SBAR. We got electronic patient record. So electronic patient record gives the benefit of whenever the patient is being seen, you document that any other professional involved with the patient, they can see the documentation, what you have done with during the consultation. A summary in the form of I-SBAR gets documented immediately after the clinic, so that it's visible to everyone. The dictation of letter can take time, because the typist have to type it, and then you have to check the letter, and then it goes to the GP. But the progress note you have written based on I-SBAR is visible to everyone. And when the CQC team arrived, they looked through the progress note I-SBAR tool, and they were highly impressed that how it has been consistently implemented across that care group. So I think I-SBAR tool is a very good model, and you can change according to your specialty. Because in my presentation there was one A4 format. You can change according to.
So you are saying that I-SBAR is not only sufficient in terms of improving the verbal communication, but has a very important role in the written documentation.
Written. There are various models for written communication. You must have heard SOAP, subjective, objective, assessment, and plan.
Plan of care.
So you can use various, but it's better if you use the one standard tool across everything. I-SBAR that you can use for handover, you can use for verbal communication, you can use for written communication, and then modify according to your specialty.
Thank you, sir. And that answer was really enlightening. I just want to highlight that the NABH in India also wants this standard format to be implemented by all the accredited hospitals. And the plan of care, as you mentioned correctly, should come after the objective evaluation of all the patients. And there is a standard format for referrals. Absolutely, I completely agree with you that we should have a standard format of documentation which should be implemented. Thank you.
Thank you, Dr. Subro sir and Dr. Verma sir for those insights. And we have a question from our Chief Nursing Officer. How about this documentation really eating into patient care as a major concern? May I direct this to Dr. Umesh sir? We stress on documentation a lot, but then does that take away the time from patient care? In fact, it is a major concern among the nursing fraternity. So how do we deal with it, sir?
Important question. And I think, we must not have too many documentation, too many steps spoil the broth. So what we need is make it very simple for the nurses, single case record, make it electronic, and make it very simple. Because Albert Einstein said something: any fool can make things complex and complicated. It takes a touch of genius to make things easy and effective. Nurses, we are taking them away from the patient care, and most important is nursing. So what we got to do is make it very simple and make it electronic. That is what I advise everybody. When you do electronic, and secondly, observation of the patient, you can do automatic. Because now with the internet, you've got all these facilities. And in Britain, when we started, it saved us a lot of money. And that's the reason why we must make sure documentation is very effective, very easy. Because if you make it too complicated, you take them away from the nursing care.
Thank you, sir. That's very pertinent. The 2 points that you mentioned, one is to keep it very simple, and the second is try and make it electronic. So I think that answers the question, though the nitty-gritties of it, hospitals have to work out, regulatory bodies have to work out. What's your perspective on that? What's your take on that, Raj, sir?
Yeah, it's a very good question, because we don't want our nursing colleague to leave the patient care and just spend all the time in documentation. I think the nursing colleague are basically there to provide care for the patient, monitoring all this early warning score. In I-SBAR tool documentation, I would expect contribution from the nursing colleague, particularly assessment. So if the doctor is documenting I-SBAR tool about the progress of the patient, they will take information from the nursing colleague, and doctors are going to document. I don't want any additional documentation pressure on nursing colleagues, because whatever documentation they are doing, as long as we are using the same case notes for nursing documentation and medical doctors documentation, it's good. Because even in UK, in the past, there used to be a separate nursing note and separate doctor's note, which was not helpful.
Do we have simplified modules of this? Because what's happening today is the NABH has got its own extensive documentation procedures, which I find certainly is cutting into patient care.
Yeah.
And that doctors have to keep writing. See, that I noticed that when a patient comes into ER, there are at least 5 different forms that 5 different people have to fill up.
Yeah.
Do we have a simpler model somewhere?
Again, this is the problem even in UK, because there are so many assessment form needs to be done when the patient hits the ED, related to various protocol or care pathway. I think, on my reflection, I-SBAR gives you the simplest tool, because you can even write in bullet points. You don't have to describe. So situation is problem, so just write down 4 bullet points. Okay.
Yes.
Past background, you can write just 4 bullet points. Assessment is the only area where you have to give summary of your assessment based on some of the investigation or observations, nursing observation, and your clinical opinion. And then again, recommendation, you have to be brief, some bullet points. So that's give. So even in the presentation, we got one A4 page. But again, if you are saying that you got so many documentation to complete, you can summarize further, because when I was giving example of I-SBAR, which I have introduced, it takes literally less than 2 minutes to finish one progress note based on I-SBAR. Whereas when we dictate letters, it takes 15 minutes to dictate the letter based on consultation. But putting on the record, it takes less than 2 minutes, because we are just using bullet points.
Thank you, sir. Thank you very much.
So one final question. What is your take on multidisciplinary notes?
Okay. So when you say multidisciplinary note, do you have access to electronic patient record?
Yes, we do have.
Good. So when you got electronic patient record, you can use your Zoom platform, or even Microsoft, which we are doing in UK, we are using Microsoft Teams to do our MDT meetings. And we are recording. So you can do a recording of MDT. So make sure that there is a chair who is allowing rest of the multidisciplinary team to input their opinion about a particular patient, and you got a recording. And at the end, you summarize. Because sometimes recording for 1 hour meeting can be very long, but you can summarize it, salient point in 1 page. But yes, there is no specific tool in my knowledge. We can't use I-SBAR tool for multidisciplinary meeting because it will depends on a complex situation you are dealing with, and input from every professional is important. So it's basically the question of a good business support. A good secretary can summarize the MDT meeting very nicely, and then you have to do the editing afterwards. So as for example, the MDT meeting which I chair, I sometimes get 5-6 pages of the minutes because it has been typed exactly from the Microsoft Team meeting. But then I summarize the whole 5-page into 1 page, because we do all are human being. We digress from the main topic, and sometimes we talk too much, and that's unnecessary things can be taken out. So I think you need a good secretarial support there and good kind of editing skills on the chair.
Thank you, sir. I would just like to one thing that we only have EMR and OPD as of now. So I think we'll have to update to what you said. And I think Philip Matthew, sir, can share more on that. Please unmute, sir. Sir, if you can unmute, please. You're not yet unmuted. Yeah, there you are.
So we do multidisciplinary meetings in the ICU itself, and we bring in all the teams involved, and we have our own means we summarize after the end of the meeting. We summarize, and probably I make a note, or the primary consultant would make a note in the file that this is what we have described. This is what we have come to a conclusion from all the discussion, and this is what we have something that we have explained to the family after the meeting as well. So probably that is more crisp. That
I agree that a clinician summarizing the multidisciplinary meeting is always better, brief, crisp. But when I'm talking about multidisciplinary, I was assuming that others meeting which I have to do with some of the external stakeholders, where there are too many people involved, so that we usually do on Microsoft Teams due to COVID-19. But yes, in ITU situation, the consultant leading the discussion, they can quickly summarize. It's much better.
Thank you, Raj, sir. Thank you. Thank you, Minimum, for that question. Umesh, sir, is coming in. Yes, sir.
I just want to say, from the head, if clinician take the lead, consultant take the lead, everything becomes easy. And that's the reason why clinician must summarize, because we got the most knowledge and everybody respects us. And that is the reason I'm very particular. Consultants must take the lead and summarize it, because we have to make our junior doctors, nurses' job easy. And that is what we got to do. And with artificial intelligence and with electronic, a lot of things are going to be easy. I was amazed. I went for a conference in Oxford, and I was amazed what is coming in next MRI, next CT scan. They will come with the result. So lots of things are going to change. And Samsung is bringing now, and Google is bringing next program. It will summarize your team meeting very quickly. And that's the reason why I'm very optimistic. Digital transformation, artificial intelligence, strong leadership from the clinicians and the consultants, and will transform healthcare throughout the world.
Thank you, sir. That's a very refreshing perspective from you. In fact, it is digital transformation that is taking the lead ahead of all of us. And I think we need to harness that energy of digital transformation to make patient care much more feasible and better. So if there are no more questions, I think we are coming to a close of a wonderful session, such an amazing session. We are already getting a lot of feedback. Our CNO has written to us personally about the session. She's extremely grateful for the session. And I can see George Chandri sir very happy. Yeah, and even Dr. Subrajyoti. And final words from our panelists and speaker before we close the session, if anybody would like to say something, or yeah.
I'll just say that this is a journey which I have taken in my organization of transforming communication. I will be really interested and happy to share or help anyone from any organization in India or anywhere, because it will be a project which will take at least 6 months or a year to get where I want the organization to take. So I'm more than happy to share in future.
Thank you very much for that, sir. We really look forward to support, guidance, and help from you, because we want to join you in that journey. And I realize it's not easy. Thank you so much for that offer.
Communication skill and medication error. Focus on these two things. Your institution can do a lot. And you've got an amazing institution. And for India, you can be an exemplar, and you can be an institution where you'll be very proud. We started the journey and others followed. That is what leader does. And I want to thank all of you for doing this fantastic work.
And I want to end by saying thank you once again, but then definitely, communication, I think, is an art and a skill which has to be learned and has to be improved. So nobody is born communicator. We all learn through practice. So practice makes a man perfect. Keep practicing. And lastly, as I say to all my young clinicians, is documents are your best friends and the worst enemies at the same point of time. So keep them to, and absolutely make them your friends. Don't make them enemies. So be safe. Have a great new year ahead. I'm wishing that the pandemic comes to an end very soon. See you soon.
Thank you, Dr. Umesh sir and Dr. Subrajyoti sir. It was indeed a very fruitful discussion. I'd like to thank our speaker, Dr. Raj Verma sir, for that amazing perspective that he threw, and Dr. Umesh sir for coming in with, again, a lightning perspective. And Subrajyoti sir, your sage-like calmness really encourages us, and the words that come out really brings us a different angle every time. So thank you, and grateful for that. And before closing in, we have a very special guest in our midst, Dr. J. Jayalakshmi. It's a great honor, ma'am, to have you with us.
Thank you so much.
Thanks,
Jacob. It was a wonderful session. Wonderful session. Thank you, all of you. And wishing you all a very, very blessed 2021.
Thank you, ma'am. Thank you for coming in. It's a great encouragement to see you. Looking forward to a session from you too. Sure. I think it's due. It's long due, I guess. So thank you, ma'am. And thank you, Dr. Philip Matthew, sir, for your astute moderation. It's been an amazing journey this last 2 hours, and extremely grateful for all of you to have come in, and our participants, thank you for tuning in. Students, I'm very sure that this session will really be fruitful for you in the long run, though you might not understand much at this juncture. And so wishing you all a wonderful new year. And ironically, this is 2021, but I would say that 2020 did not win. We still won. Okay. So I hope that this year is a great blessing for all of us. And on the 6th, we have another international webinar coming in on allergic rhinitis, and a world authority, Dr. Glenys Cadding from UK, is presenting on allergic rhinitis. And I hope to see you all then. Until then, take care. Stay safe, and God bless. Have an amazing weekend.
Thank you.
Signing off from Believers Church Medical College.
Bye.
Thank you.
Thank you. Bye-bye.